There is a clinical instrument called the ankle brachial index test. Most people over 60 have never had one performed, and most physicians never order one unless symptoms are already clearly present. The test itself takes fewer than 10 minutes. A blood pressure cuff placed on the upper arm, a second cuff placed on the ankle, a simple ratio calculated between the two readings. What that ratio reveals is the degree to which arterial disease has progressed in the peripheral vascular system, and by extension, the likelihood that the same pathological process is occurring simultaneously in the coronary arteries supplying the heart and the carotid vessels supplying the brain. It is one of the most inexpensive, non-invasive, and diagnostically informative assessments available in all of cardiovascular medicine. It is also one of the least routinely performed in primary care settings for asymptomatic patients over 60, a gap that has real clinical consequences for people who would benefit from earlier identification. The test exists because atherosclerosis, the progressive narrowing and hardening of arterial walls produced by the accumulation of lipid-laden inflammatory plaques within the innermost layer of the vessel wall, does not develop in one artery in isolation. It is a systemic, diffuse disease. When it appears in the femoral or popliteal arteries of the lower leg, it is present, in varying degrees, throughout the entire arterial tree. And crucially, by the time a test result shows a clinically significant abnormality, the disease process has typically been underway for 15 to 20 years. The vessel walls have been remodeling in silence. The luminal diameter has been narrowing in increments too small to produce symptoms. The endothelial surface has been accumulating inflammatory and structural change across years of exposure to mechanical pressure, oxidized lipids, and reactive oxygen species. The person in whom all of this is occurring has, in most cases, felt entirely well. That is the defining feature of this disease. And that is what makes understanding its early signs not optional but necessary. Atherosclerosis carries its clinical designation as a silent disease because the coronary arteries, the carotid arteries, the iliac vessels, and the renal arteries contain no nociceptive nerve endings in their walls. The tunica adventitia, the outermost structural layer of the arterial wall, contains vasomotor nerves that regulate vessel tone and respond to stretch. But these fibers do not transmit pain signals to the conscious brain in the way that somatic nerve endings in skin, muscle, or periosteum do when those tissues are damaged. A vessel can lose 40, 50, even 60% of its internal diameter before producing hemodynamic changes sufficient to generate symptoms perceptible without specialized imaging. This is the foundational clinical challenge of managing arterial disease in people over 60. The biology of the disease and the biology of human pain perception are misaligned in a way that consistently and predictably produces delayed recognition, delayed diagnosis, and delayed intervention. What we now understand from decades of longitudinal imaging studies, large autopsy series, and large-scale epidemiological data following tens of thousands of patients over multi-decade timeframes is that the arterial changes associated with significant cardiovascular risk are not only present long before any diagnostic cardiac event, they produce a specific and identifiable set of physiological changes that manifest as observable and recognizable symptoms in the body's peripheral systems long before the central vessels reach critical narrowing. The 6 signs we are addressing in this video are not theoretical early warning signals invented to generate concern. They are the downstream, physiologically inevitable consequences of altered hemodynamics, reduced tissue perfusion, modified autonomic function, and the compensatory physiological adjustments the body makes when arterial narrowing reaches the degree that changes how blood moves through the peripheral circulation. Each one can be assessed at home in under 5 minutes without any medical equipment. Each one, considered in isolation, carries a clinical differential that extends beyond arterial disease. But taken together in a person over 60 with one or more established cardiovascular risk factors, they form a clinical picture that warrants formal medical evaluation without delay. That is the framework for everything that follows today. The arterial system is not a passive network of tubes. It is an active, pressure-regulating, biochemically responsive infrastructure that adapts continuously to the demands placed on it across every decade of life. After 60 years of use, that infrastructure has been exposed to variable blood pressure loads, variable lipid chemistry, variable inflammatory signaling, and the continuous mechanical stress of 3 billion or more cardiac cycles pressing outward against vessel walls with every beat. In most people over 60, that accumulated exposure has produced measurable changes in arterial wall compliance, endothelial function, and luminal geometry, changes that are invisible on the outside and produce no sensation from the inside. These changes are not inevitable in their severity or their trajectory. The research on this is consistent. They are meaningfully modifiable when identified and addressed. But modification requires recognition first, and recognition requires knowing precisely what to look for in a body that communicates through the only language available to it, which is physiological. The 6 signs that follow are that language, translated into something you can evaluate at home before this week is over. We are going to read each one carefully. There are 6 of them. Each one is accessible. Each one matters. The first sign is persistent coldness or numbness in the feet and lower legs, particularly when present at rest or in environments that should be warm enough to maintain normal peripheral skin temperature. The peripheral arteries of the lower extremity, the femoral artery in the upper thigh, the popliteal artery behind the knee, the anterior and posterior tibial arteries in the lower leg, and the dorsalis pedis artery running across the top of the foot are among the first vessels to develop hemodynamically significant stenosis in the course of systemic atherosclerosis, when luminal narrowing in these vessels reduces the downstream perfusion pressure to distal tissue. The cutaneous circulation serving the foot and ankle is the first to be compromised. The skin arterioles of the foot operate with lower baseline perfusion pressure than the muscular arterioles of the calf and thigh, and they have minimal autoregulatory reserve to compensate for reductions in upstream supply. The practical consequence is feet that remain persistently cooler than the ambient temperature should allow, that recover slowly after active warming, and that may develop numbness or tingling during prolonged periods of inactivity when there is no muscular pump activity to assist circulation through the extremity. The clinical distinction between arterially mediated cold feet and non-vascular causes lies in specificity, symmetry, and environmental independence. Arterially compromised feet remain cool in warm environments. They may demonstrate measurable temperature asymmetry between the two sides when unilateral vessel disease is present. They do not respond normally to the room warming or to thicker socks. Place a hand flat against the sole of each foot right now. Then move both hands to the anterior surface of each shin, halfway up. In a healthy peripheral arterial system at normal room temperature, the temperature difference between the foot and the lower leg should be minimal. A consistent, significant temperature gradient in which the foot is persistently cooler than the proximal lower extremity in a warm environment is a finding that deserves to be pursued. Most people have attributed this to poor circulation in a vague and general sense for years without ever having the specific vascular question asked or answered. It is often the first coherent message the arterial system produces, and it is routinely overlooked. The second sign is reproducible fatigue, cramping, or heaviness in the calf or thigh that develops during walking at a predictable and consistent distance and resolves within 5 to 10 minutes of stopping activity. This symptom pattern has a formal clinical name: intermittent claudication. It is produced by exercise-induced ischemia in the skeletal muscles of the lower extremity when narrowed proximal arterial vessels cannot increase blood flow in proportion to the rising metabolic demands of physical activity. During sustained walking, the oxygen requirements of the gastrocnemius, soleus, and quadriceps increase substantially above resting levels. In a healthy vascular system, the resistance arterioles supplying these muscle groups dilate in response to local metabolic signals, including locally released adenosine, rising carbon dioxide tension, falling oxygen tension, and decreasing local pHe, increasing blood delivery proportionally. When a fixed resistance stenosis exists in a proximal vessel, such as the superficial femoral artery, that compensatory vasodilation cannot overcome the hemodynamic resistance imposed upstream. The muscle is forced into anaerobic energy production. Lactic acid accumulates in the interstitial space. The resulting cramping or heaviness becomes severe enough to force the person to stop walking. With cessation of exertion, metabolic demand falls back toward baseline, anaerobic metabolites are cleared, and symptoms resolve. The cycle repeats at approximately the same distance on the next walk. This reproducibility, the same distance, the same symptom, the same reliable resolution with rest is the clinical fingerprint of claudication that distinguishes it from musculoskeletal pain, which tends to be less predictably reproducible and less reliably position-dependent. The third sign is erectile dysfunction in men, which the majority of those affected, and unfortunately, a significant portion of their physicians, continue to interpret primarily as a hormonal or psychological phenomenon rather than a vascular one. The internal pudendal artery and its terminal branches, specifically the cavernous arteries supplying the corpus cavernosum, are small caliber vessels that reach hemodynamically significant stenosis earlier in the progression of systemic atherosclerosis than the larger coronary arteries do, because their smaller diameter means a given amount of plaque burden represents a proportionally greater reduction in luminal area. Progressive erectile dysfunction developing after 60, in the absence of a clearly identified hormonal deficit or psychological explanation, is now formally recognized in cardiovascular medicine as a potential sentinel marker for systemic arterial disease, sign appearing on average 2 to 5 years before coronary artery disease produces angina or a cardiac event. This relationship is documented, replicated, and clinically significant. It should inform the diagnostic evaluation that follows. The fourth sign is transient visual disturbance, brief episodes of blurred or darkened vision in one eye, or the characteristic sensation of a gray curtain descending across the visual field, lasting seconds to minutes before clearing completely without treatment. These episodes must not be minimized or rationalized as fatigue, screen exposure, or dehydration. The ophthalmic artery is the first named branch of the internal carotid artery as it passes through the carotid siphon. Embolic material originating from atherosclerotic plaque within the cervical carotid artery, cholesterol crystal fragments, calcified debris, or platelet aggregates released from an unstable or ulcerated plaque surface can travel distally through the ophthalmic artery and lodge temporarily within branches of the central retinal artery. The resulting visual disturbance, when monocular and transient, is designated amaurosis fugax. It resolves when the embolus fragments or moves further downstream. But the resolved visual symptom is not the clinically significant finding. The significant finding is what it reveals about the ipsilateral carotid artery. An embolus reached the retinal circulation from an unstable carotid plaque. That same plaque is capable of generating embolic material that reaches the middle cerebral artery or the anterior cerebral artery rather than the ophthalmic branch. The anatomical trajectory of that material is not under volitional control. Amaurosis fugax is a warning event for ischemic stroke and requires urgent carotid duplex imaging. The fifth sign is exertional chest discomfort, tightness, pressure, heaviness, or constriction developing during moderate physical activity, such as climbing stairs, walking at an incline, or carrying bags, that resolves predictably within minutes of stopping. This is stable angina pectoris. Exercise-induced ischemia in the myocardium produced when coronary artery stenosis prevents the increase in myocardial blood flow that the working heart requires during increased cardiac output states. The left anterior descending artery, the left circumflex artery, and the right coronary artery each supply discrete territories of myocardial tissue. Stenosis sufficient to limit the perfusion reserve of any of these vessels produces downstream ischemia under demand. In people over 60, the presentation deviates frequently from the textbook description of substernal chest pressure radiating to the left arm. In women particularly, and in older adults generally, the presenting symptom may be unexplained breathlessness on exertion, jaw or neck discomfort, a heaviness between the shoulder blades, or simply an unusual and unfamiliar fatigue during activities that were previously tolerated without difficulty. The absence of classic chest pain does not lower the clinical significance of these symptoms. It raises the risk of misattribution and diagnostic delay. The sixth sign is a blood pressure differential between the two arms exceeding 10 millimeters of mercury on systolic measurement, identified on readings taken at the same visit under the same conditions. The overwhelming majority of people over 60 have had blood pressure measured hundreds of times across their lives, and in virtually all of those measurements, only one arm was used. Standard clinical practice for routine blood pressure monitoring defaults to a single arm reading. However, the subclavian artery, which originates from the aortic arch and provides the primary blood supply to each upper extremity, can develop significant atherosclerotic stenosis, most commonly on the left side. When it does, the downstream blood pressure recorded at the brachial artery of that arm is lower than the contralateral side. A difference exceeding 10 millimeters of mercury between the two arms in the same clinical setting is a hemodynamically meaningful finding. A difference exceeding 15 millimeters is associated in the cardiovascular literature with substantially elevated risk of vascular events and increased all-cause cardiovascular mortality, independent of other risk factors. Beyond the pressure differential itself, the vertebral artery branches from the subclavian artery at a point proximal to the typical stenotic segment. Under conditions of increased metabolic demand in the muscles of the affected arm, the vertebral artery can reverse its normal direction of flow, drawing blood retrograde away from the basilar circulation to supply the arm pos, a phenomenon called subclavian steal syndrome. This can produce posterior head pressure, dizziness, or presyncope specifically during upper extremity activity on the affected side. Measure your blood pressure in both arms today using a standard home blood pressure monitor. Record both systolic numbers. If the difference is greater than 10 points on the systolic reading, that is a specific finding to report to a physician by name at your next visit. Each of these 6 signs carries alternative explanations beyond atherosclerotic arterial disease, and clinical precision requires acknowledging that clearly. Cold lower extremities can reflect peripheral neuropathy from diabetes or nutritional deficiency, hypothyroidism, or vasospastic conditions like Raynaud's phenomenon. The reproducible exertional leg symptoms of claudication can mimic lumbar spinal stenosis, hip osteoarthritis, or compartment syndrome. Erectile dysfunction in men over 60 has identifiable endocrine, neurological, and psychological contributors that must be part of any proper evaluation. Transient visual disturbances can originate from ocular disease, migraine with aura, or vertebrobasilar insufficiency from non-atherosclerotic causes. Exertional chest discomfort has pulmonary, musculoskeletal, and gastrointestinal explanations that must be excluded. The arm blood pressure differential can reflect measurement technique variation or subclavian pathology unrelated to generalized atherosclerosis. What transforms any one of these findings from a nonspecific observation to a vascular signal requiring investigation is clinical context. Specifically, age over 60 combined with one or more of the established cardiovascular risk factors: hypertension, type 2 diabetes, dyslipidemia, current or former tobacco use, central obesity, family history of premature cardiovascular disease, or chronic kidney disease. In that context, the co-occurrence of 2 or more of these signs is a pattern demanding evaluation. What can be done about arterial disease when identified early is both substantial and well documented. Mediterranean dietary patterns reduce systemic arterial inflammation and slow plaque progression across multiple controlled trial populations. Sustained moderate intensity aerobic exercise improves endothelial function, stimulates collateral vessel development in territories of compromised perfusion, and reduces arterial wall stiffness through mechanisms independent of its effects on other risk factors. Blood pressure control to current guideline targets eliminates the primary mechanical driver of endothelial shear damage and reduces the hemodynamic forces that destabilize existing plaque. Tobacco cessation at any age restores measurable endothelial function within weeks of the last exposure. These interventions are available, effective, and within reach. They require a decision and a starting point. The gap between having this information and acting on it is not a knowledge problem, it is a decision problem. This video addressed the first. The second one is yours. We began with a test: ankle brachial index. 10 minutes. A blood pressure cuff on the arm, a cuff on the ankle, a ratio calculated between the 2 readings. If you recognized yourself clearly in one of the 6 signs described in this video, bring that observation to your next physician appointment and request an ankle brachial index assessment specifically by name. Write those 3 words on your phone right now so they are available when you need them. If you recognized yourself in 2 or more of these signs, particularly in the context of any established cardiovascular risk factor, do not wait for a scheduled visit. Contact your physician's office today and describe what you observed. Explain which signs you identified and how long they have been present. The arterial system does not operate on appointment schedules or wait for convenient timing. It operates under continuous pressure, every hour of every day, processing the accumulated consequences of decades of biological and lifestyle history in real time. The signs it produces when intervention is still meaningful are quiet ones. Quiet by the nature of the disease itself. Quiet in a way that makes dismissal easy and recognition rare. You have now been given the information to make that dismissal harder. The next step belongs to you, and it starts today.